show me that they really have that much pain. So then, I'm a really slow learner. I went to, well, you shouldn't have this much pain. And, again, they would show me. And, on and on and on. I kept a very slow learner. How could you have this much pain? And they would tell me, well, I took out the trash, or I did this or did that. But, after more years than I'd like to admit, I found that if I would just validate the pain and take that away, then my other interventions could be effective. But it did take me a while to learn that, longer than I would like to admit. Any questions so far? Because I'm rushing through and I'm almost done.
I was at a conference a couple weeks ago, and I had talked to somebody, I can't remember who, I have to look up my notes, but they had talked about how opiate meds can trigger fibromyalgia. Can you talk about that a little bit, or is there any history that you've heard about that?
Well, I know there's some people here who can talk about that. We do know with prolonged opiate use that you do become more hypersensitive to pain, that your receptors are more sensitive to pain. So I haven't heard it related specifically to fibromyalgia, but I'd say no matter what, that happens. And you see that with your clients who are taking large amounts of opiates. They're the ones who tolerate the least amount of discomfort, right? You experience that? And, they do become more sensitive. There's some school of thought that maybe fibromyalgia is a central nervous system issue, right? And also there's a thought that the opiates affect the central nervous system too, to make you more hypersensitive to pain. So it makes sense. I don't know if any of that's been proven yet. Anybody else more up to date on that? But it definitely makes sense. And if it is somehow centrally nervous system correlated, then both of those, then that would be a logical conclusion. But we definitely see that with our clients. They come in on so many opiates that you should be able to, cut off their finger and they wouldn't feel it. But they have very, very low tolerance for discomfort. And again, that's what we would validate. I would never say anymore, well, that shouldn't hurt. That chair is not that uncomfortable. Everybody else sits in it. And those are whole other schools of thought, the dialectic behavior therapy, motivational interviewing. But I just try to avoid the whole argument. I validate their pain. I validate their experience of the pain. I believe that what they're telling me is their true experience of the pain. And to some degree, it takes that away so then we can, work on other things. It takes it away so we can offer some hope. But we do have, we do have a large array of things that we try with our clients: physical therapy, massage therapy, counseling, individual, couples, family therapy, chiropractic, acupuncture. And a person may go through all of those specialties while they're here because they would say it's not effective. But concurrently, they're dealing with their addiction as well, and they're getting off of those medications. Just from our experience, they're automatically going to feel better. So when I put even yes position.
I just wanted to add that because you mentioned patience, and that's a real tough concept for people who have an addictive mindset. So even if they didn't have the addictive mindset, they would have to be patient. But people in our society is right now, it's been telling us we need relief immediately.
Absolutely.
And then when you put the addictive mindset on top of that, it's really difficult to get through. And they need to be patient and let the treatment work in its time.
Exactly. Yeah. I agree with her 100%, and I know you guys see, I don't feel any better. We want immediate satisfaction. Again, I agree with you 100%. So we don't rapidly switch from these things, but until we push them as far as we can with each specialty, and they're really pushing back, like, I gotta go because this isn't working. Let's try this. I agree with you 100%. Instant gratification. I want it too when I'm in pain. When I have a headache, I want it gone immediately. So finally, don't be afraid, this pairing of pain and addiction. And I know there is some concern, because if you are a drug and alcohol counselor, how do you know something's not really wrong with this person, right? I don't know that they don't have something seriously physically wrong with them. Or the converse to that, the you're faking, that very confrontational. I found that not to work at all. Nobody says you're right, I'm just doing this so I can get drugs.
I've seen over the past few years a marked increase in the number of patients that come to the diagnosis of fibromyalgia. And whenever you try and lessen their pain medication, they jump right back to that diagnosis. But I have yet to find one person who's been able to explain to me exactly what fibromyalgia is.
It's true. Well, with an easy Google search, there are streams of studies on the benefits of activity, exercise for fibromyalgia. Not too much, because they can do too much, but just the right amount. So I'd introduce that too. We have a number of our clients, have a diagnosis of fibromyalgia, and typically they're taking, lots of stuff, right? Not just opiates, but benzos and sleep aids and antidepressants. And, they take a lot of medication.
And it's unspecified pain.
Right.
Okay.
Right.
But I think the doctors aren't informed well enough about alcohol and drugs. They're kind of afraid of it. So it's like the guy, you stick him in the hospital because they picked him up off the street that was drunk out of his mind and hurting himself, and they put him in the hospital, and they just want him out as soon as possible because they really don't know how to treat him. And the same thing with a lot, the clergy, everything. There's people that really don't understand. Hopefully, I've been retired for 6 years, but hopefully in that 6 years maybe something has happened to make that better. But I don't know.
What do you guys think?
I don't think it's, I think if anything, because I know we see it a lot with ours, doctors will, 2 seconds, all of our kids all they have to do is go into a doctor and say, hey, and they'll give them 3-4 days off school, off work. I've been one of our kids, big time drug seeker, cocaine addict, he had pneumonia, and for a couple days in the hospital, he was pumped full of all kinds of morphine, and just loving it with his morphine, because it's just
They give them more than one.
Yeah.
Oh,
I
yeah.
had clients, I had to call the doctor and say, what are you doing? You can't do that. Check and see what their background is. So, and they're actually pretty nice once you let them know what's going on,
Sometimes.
but they don't know. Yeah, sometimes they're a little bit, I'm the god here and you guys aren't. Some have that attitude, but not a lot.
Well, I think that the relationship between the physician and the patient changes into a dealer-addict relationship. And, what we've done in the past is actually talk to the patients off of their relationship with physicians and try to limit that, because they really are somebody that
Well, until you do that, you can't find out which it is.
Right.
They could have some occurring disease or illness, but if you don't find it out, you'll never know that.
that illness isn't what's killing them, it's the addiction.
Right.
It's
Right,
important.
it's the top priority.
It's important to have a relationship with a physician that is knowledgeable about, addictive medicine, because in weaning someone off of their addictive relationship to physicians, we also need to be aware of, the physical problems, so that we're not interfering with their bona fide medical treatment.
I don't know that it's any better. We take occasionally our clients to some local urgent cares. And we go in with them and say they're in drug